Hello and welcome everybody. And today I'm very pleased that we're going to do another of our British Skin Foundation Q&A sessions. So big shout out as always to the British Skin Foundation in supporting us in delivering evidence-based information, which allows us, doing our clinics and our Q&A sessions, allows us to get questions that you have straight out to consultants, dermatologists, who we know are so hard, sadly, to be able to see nowadays in the NHS. You can see them, but you're going to have to wait a little while, unfortunately. So welcome, Rishika. So this is Dr. Rishika Sinha, who is a consultant dermatologist. Welcome.
Thanks so much, Katrina, and thanks for inviting me to chat to you this evening.
Would you like to tell everyone a little bit of your background?
Yeah, sure. So I trained at Cambridge Medical School and then decided to go into dermatology in 2008. So I've trained in some of the big London teaching hospitals. I did my dermatology research mainly on metastatic melanoma. But throughout my entire dermatology career, my focus has been on general dermatology. So in general dermatology, we see lots of psoriasis, eczema, acne, rosacea, really common skin conditions. And you know, Katrina, 20% of GP consultations are to do with skin. So skin disease is really rife and obviously bothers people. So my interest is in general dermatology, medical dermatology, skin cancer. At my NHS trust, we see, as you'd imagine, a lot of psoriasis patients. And the treatment of psoriasis has really transformed, I'd say, over the past 15 years. So when I started my dermatology training in 2008, we had a range of treatments that we could offer for psoriasis, and it was pretty standard. It would be a ladder of treatment options. And over the past 15 years, the management of psoriasis has exploded. We've got a significant number of medications now available to patients that we can prescribe. But as you say, getting to the dermatologist can be a lengthy process, particularly with the pressures that are currently we're facing in the health service. So yeah.
And would you say, I mean, that's very interesting. I mean, being a fellow psoriasis sufferer myself, and I am definitely one of those, oh, just put up with it, which I think very sadly is what so many people do with skin, which is why we're very keen to always promote skin, because it is one of those concerns. People think, oh, it's just a skin complaint. And I don't think people really appreciate how deep the scars, literally the scars of skin damage or skin conditions really run in people's psyches.
Absolutely. And I think psoriasis is one of those main skin disorders that has absolutely been recognized to not be just skin deep. So a significant number of psoriasis patients also have, as you'd expect, mental health problems, depression and anxiety, loss of confidence, social anxiety. And as you say, there is in some cases, an expectation of, you know, it's just a skin problem, put up with it, but it's so much more than that. Apart from the mental health burden, we also know that psoriasis patients do often have other health problems, such as metabolic syndrome. You may be predisposed to putting on weight easily. You may be predisposed to cardiovascular problems, or in fact, inflammatory bowel disease. And these are big organs that we're talking about. So this is your overall health. And in some cases, psoriasis can be the first sign or first indicator that actually maybe there are some other health problems going on. So absolutely, psoriasis is not just a skin problem. There are many other factors to take into consideration.
Gosh, that's really interesting, because I've been very fortunate in that most people wouldn't even notice I have it, and it flares up and it goes away. But I'm very aware of some people are totally debilitated by it and are in hospital. And I thank my lucky stars that, that's not really happened to me. But I'd never realized I suppose it's because it really is one of the main inflammatory conditions, isn't it? And one
Yes.
just doesn't appreciate that. And it's very interesting that you say that, because I just wonder how many people go to the doctor and say they have these issues, and the doctor may not connect the psoriasis with particularly the bowel issues that you
Yes.
mentioned.
Exactly. And so I think that's why Q&As like this, or maybe signposting patients to the British Association of Dermatologists information leaflets, or doing a bit of research on psoriasis charity websites, you can actually get a lot more information as to what other things can coexist with psoriasis. Now, I'm not saying that everybody that has psoriasis will have these other problems, but I think knowledge is key, and understanding your body is key. So knowing that psoriasis is a significant chronic inflammatory skin condition. The skin is the largest organ of the body. So if you've got inflammation in your skin, you may have inflammation elsewhere. And how can that be picked up? Now, sometimes you can pick that up with symptoms. So are you going to the loo more often? Are your bowels not feeling right? Is there blood in your stool? Or it might be something completely invisible that might need a blood test. So you might want to check for your HbA1c, which is a measure of your glucose levels. You may want to have your lipid levels checked, which tell you if your cholesterol is high or low. And that can sometimes be raised when you've got inflammation. You may want to have your blood pressure checked at the GP's practice or by a home blood pressure machine. And that could tell you, look, is my psoriasis causing inflammation in other parts that I'm not aware of? So I think there's, knowledge is key with a lot of health conditions, if not all. And knowing that psoriasis is basically chronic inflammation, and that can lead to inflammation elsewhere, might help some people put pieces of the puzzle together and help them understand how they're feeling, why they're feeling the way they're feeling.
I mean, exactly. And at Talk Health, that's what I want us to do, is it's not to frighten people by saying, oh my God, it could be this, it could be that, but just to make people aware so they can make an informed choice
Absolutely.
to understand. Because you're right. I mean, it's impossible for a doctor to understand everything when you go and see them for a few minutes. It's very difficult, isn't it? But the more that you know and can do background checks, I think the better.
And also, you can direct the conversation.
Yes.
So you can say, well, actually, I've got this and I've read about this and I've measured this. Can you just confirm if there's an issue or not? And obviously, reassurance is key. So,
Mind you, every time I've done that, and I always say to people, don't go and Google anything. I obviously do. And we present it to the doctor and they always say, no, it's not that at all. It's something else. I've tried. And I think that we're probably all a bit like that. But you might just hit upon that thing and where it could be really important. Anyway, enough about my sad Googling. Let's go on to the Q&A sessions. So these are some of the questions that we've picked out that have been sent in by our members. So can you have more than one type of psoriasis either at a time or separately?
yes, you can. It's not very common, but you can. So just to, I guess, look at the broad picture. So there's 5 main recognized forms of psoriasis. One is chronic plaque, which is the red scaly patches generally on what we call the extensor surfaces, so the outside parts of our skin, which are elbows, knees. Chronic plaque also tends to occur on the torso and the limbs. The other type of psoriasis, which I think a lot of people have heard about, is guttate psoriasis. And guttate psoriasis is where you can get small raindrop types of scaly plaques, particularly on the back. And it's usually precipitated by a throat infection, so streptococcal throat infection. And that tends to arise more in children. And so that's guttate, but you can get it at other times in your life as well. Then you've got inverse psoriasis, where you tend to get psoriasis on your skin folds. So that can be under the arms, under the breasts, or in the groin or the genitalia. Then you can get a rare form of psoriasis called pustular psoriasis, where the red scaly plaques develop yellow pustules on them, and these yellow pustules are quite flaccid, they break easily. And pustular psoriasis is actually regarded as an emergency, and patients can become very unwell. They can lose a lot of heat, fluid, they lose temperature regulation, so they really need to be managed in hospital by doctors. And the fifth commonly recognized form of psoriasis is erythrodermic psoriasis. So that's where a significant proportion of your skin becomes red and inflamed. And that is often due to medications or infections. Now, commonly we see chronic plaque psoriasis or guttate psoriasis. And chronic plaque can turn into pustular or erythrodermic psoriasis if that person comes across a particular trigger. So the triggers for those two forms of psoriasis can tend to be medication or infection. It's rare, it's not very commonly seen, and we tend to manage those types in hospital. Now, you might have chronic plaque psoriasis, which is pretty stable, and you might find that a few years or decades down the line, you might end up developing inverse psoriasis. And that can be because chronic plaque psoriasis can make some people gain weight. And that's a complex link, but we do know, research has shown that when you've got chronic plaque psoriasis, you do have a tendency to have a raised BMI. So if you gain weight, your skin folds actually rub against each other. And when the skin folds rub, you can trigger psoriasis. So you can have chronic plaque with inverse. You may also have very stable chronic plaque psoriasis, which may fluctuate, come and go. And then if you catch a streptococcal throat infection, you may develop guttate psoriasis. So it's not common, but it can happen.
Thank you. And funny enough, going on to the next question is what normally triggers psoriasis? And so you've already told us one of the triggers.
Yeah. So I sort of generalize in terms of the triggers of psoriasis, or the triggers of a lot of autoimmune conditions tend to be, for me, 4 things: stress, smoking, illness, infection. So I think stress has been increasingly recognized as a trigger of psoriasis. And it might be good stress, like getting married, or it might be intense stress from work or personal issues. And we know that stress causes inflammation in the body. And because we know psoriasis is an inflammatory problem, it contributes to psoriasis. So stress can be one. Infection we've spoken about. So the commonest infection that can trigger psoriasis is streptococcal throat, but we know that HIV in some instances also triggers psoriasis. Other illnesses can also trigger the onset of psoriasis, and that's often because other illnesses can cause stress on the body, which in turn causes inflammation. Other common triggers of psoriasis are skin injury. So there's something called Koebner phenomenon, which I find really interesting, and it's basically where you injure the skin, you develop the skin disease in the site of injury. And for some people, that can be the first sign of psoriasis. So you may have a knee replacement or skin surgery for a mole removal, for instance, and you can develop psoriasis in that site, and that might be the first sign of psoriasis. So those would be the common things, I'd say.
It's funny, isn't it? The body is just waiting for something not to be right to trigger these other underlying things that can just come out.
Yes, exactly. So what we know, again, what's interesting about psoriasis that's been discovered over the past couple of decades is the genetics. So we know that genetically you tend to be predisposed to psoriasis, but you need a trigger. You need sort of like a second hit. And that second hit can be one of the things that we've just spoken about. Or it might be a new medication, for instance. So we know that beta blockers can trigger psoriasis. A medication called hydroxychloroquine, which is an anti-malarial, that's a common trigger. Or lithium, which is a medication that's used for mental health disorders, can trigger psoriasis. So it tends to be sort of this two-hit theory that helps psoriasis be revealed.
Well, I absolutely got mine from a throat infection.
Ah,
I know exactly when I got it, and it's just it. And I remember thinking, well, I need to go and get some penicillin, and I didn't get at the time penicillin in time to catch it. But you know, who knew that was what it was all about?
absolutely. And what's interesting, Katrina, is even if you treat the streptococcal throat infection, it won't necessarily treat the psoriasis. So it's not going to necessarily get rid of your psoriasis because the onset for the inflammation has come on. So you're getting rid of the infection, but it's not going to change the inflammatory process in the skin.
Absolutely. Okay. Now we're on to why does my guttate psoriasis come and go as I can't work out what triggers it other than I know the sun helps.
So just going back to what we've spoken about guttate psoriasis. So we know that guttate psoriasis is commonly triggered by streptococcal throat infections. And usually, you'd be aware of that. So fevers, unwell, swollen glands, pus on the tonsils. So if the guttate psoriasis for this person is flaring up, what I would recommend is getting the throat checked. And if it's clinically indicated, to take a throat swab to look for the streptococcal bacterial infection on the swab. Because you may have an untreated infection there that is continually flaring up your psoriasis. So that would be worth checking.
I mean, for me personally, I know this isn't a consultation for me, but for me personally, I had two throat infections and that triggered it. And that was obviously many years ago. That was in my 30s. And now it's nothing to do with the throat infection, but that's exactly where it started from to get going. Right. Next question. What is the best emollient for psoriasis, and what about steroid use for psoriasis?
Yeah, good question. So emollients are basically types of moisturizers. So they keep our skin barrier intact and well hydrated. Now, there isn't any best type of emollient, and the best type of emollient is the one that the person likes to use, uses plentiful, and uses regularly. So in my experience, what works for one patient doesn't always work for the other because everybody's skin is unique. Everybody's skin type is very different. Their personal preference about the feel or the texture of the emollient is very specific to themselves. So what I usually recommend is probably a list of 3 or 4 different moisturizers or emollients for patients to try. And some of the pharmacies and supermarkets actually sell small sample size versions. So I often say, to try a few out and see what they like the feel of. Do they like the feel, the texture? Will they use enough of it, and will they use it regularly? Sometimes you have to use it throughout the day, which I understand is totally frustrating, particularly when the weather's getting warmer because it's sticky. It makes your clothes greasy. It's difficult to get out in the wash. So I think it's really important to try different formulations, see what works for your skin. I'd like to focus more on ingredients rather than specific brands. So I like to look for ingredients that have paraffin because we know they retain water really effectively. Urea, because urea is a really great ingredient for helping dissolve some of the scale of psoriasis and soften the scale. And they also help retain water. And I also really like glycerin because it's got really great humectant quality. So it helps draw water into the skin and keep it better hydrated. There's also a couple of skincare brands that are now using nicotinamide as an ingredient for skin moisturizers, and that's got really good scientific evidence behind it as an anti-inflammatory ingredient. So that I have recommended that as well. And again, sort of, responses back have been variable. Some people really love it. Some people are like, oh, not for me.
And that's interesting that the ingredients you say, because if one has to wait a long time to go and see a dermatologist, you're thinking, well, what on earth should I be looking at? Because the supermarkets are, or wherever, are full of so many of these different products that claim things. And I think it's also very difficult to know, because we know that most of these products are placed, particularly, especially if they're at eye height or easy to see, it's because they've paid more money to be on that spot, as opposed to the fact that they're better or whatever it is. So how do you know? But that's what was very interesting, having that list of recommended ingredients. And I
Yes,
think you're right. It is. I know from all the work that we've done over the years, it's been consistently using it, and to use the right amount, because people are very sparing. They never really put enough on.
absolutely.
And I think also they don't ever tell you. Well, I mean, most people don't read the directions, do they? And I think one of the directions they should make very clear is, you need this dollop for this
Yes.
leg or something.
Exactly. So I think the guidance in psoriasis isn't as clear as it is in eczema, for instance. But if I could use eczema as an example, so the nice guidance is actually to use a 500-gram pump of emollient at least every couple of weeks. So that's a huge, huge pump. And, the expectation, I often sort of set expectations for my patients, say, you know what, take the 500-gram pump, try and use it in a month. Now, with psoriasis, it might be slightly different, because the plaques might be localized. It depends on how extensive your psoriasis is, and whether you feel you need the emollient or not, really. So it's probably more difficult to be very directed about total volume. But what I would say is to use actually a really good sort of, half palm-sized amount, really good dollop, and use that for one leg, and then do the same for the other leg. So, you can sort of get an idea, once you start using more of it, actually, that your skin starts to feel much better. And using emollients sparingly is not necessarily. Use as often as possible, as much as possible.
And you're right, because I was absolutely talking about eczema then, because in eczema you always talk about quantity.
Yes.
And really you don't in psoriasis, but one should do, really, because it is always like how much or how thick or whatever.
Absolutely. Yeah. And I think, again, that's where sort of, bespoke case by case, when we see people, we can say, right, okay, for this type of psoriasis, this is what's needed. And we can tweak things as we go along. So I think that's key.
Is UVB and red light treatment the same?
Good question. It is not. So I have been asked about red light therapy more than any other topic this year. So I think it's in vogue. I think it's
Is that the red light? Do you think, sorry to interrupt, do you think that's because it's all the beauty thing, isn't it, to have these marks? And presumably, is that red light?
correct? Yes.
Yeah.
So I think because it's in the media, it's in the press, and it looks outworldly, really, doesn't it? It looks quite different to what we know home devices to be. So I think it's quite popular, and I think they're coming with a specific promise. So now, UVB and red light therapy are two completely different things, but they are both part of the electromagnetic spectrum. So our electromagnetic spectrum is effectively sort of, like the light spectrum. And UV is the radiation we get from the sun. And then you've got red light therapy, which actually sits quite far away from that. So they are not interconnected. Now, UVB has been used as a standard therapy for psoriasis for decades. It's got excellent research behind it, very good science, and repeatedly has been shown to be a great anti-inflammatory, which is how it works in psoriasis. So it reduces inflammation, suppresses the skin, and reduces the turnover of the skin cells. Now, red light therapy is very different, and it's there have been studies with red light therapy in psoriasis, but it's very small scale, and they've not been able to show repeated results as they have with narrowband UVB phototherapy. So I would say red light therapy is an emerging therapy for psoriasis, but it's certainly not standard therapy by any means. We definitely need more research, but it is being used in other areas for skin disease, so rosacea, pigmentation, anti-aging. It's being used in those spheres and sectors. So we might see more evidence coming through, and anecdotally, I hear a lot of people telling me that they feel it is beneficial, but I'm yet to see convincing scientific data. But they are two completely different things.
And I think that particularly when you are using forms of light, it is important to look at what evidence is
Absolutely. Yes.
For sure. But that would be great if it could anti-wrinkle and do your psoriasis at the same time. That would be a real coup, wouldn't it?
Yeah. Right.
Oh, and we have another, which I think I said to you earlier, we've had a lot about, which is interesting that you said that you've had a lot of light ones. We had a lot of one. Is red light therapy any good for psoriasis treatment, and what other therapies? So I think you've answered the question, is it any good? The answer is maybe, anecdotally, yes, but there's still more work to be done. But
Absolutely.
what other therapies are there?
So with psoriasis, there is a ladder of treatment, and the treatment of psoriasis is dependent on multiple factors. So one is how widespread the psoriasis is. And not only how widespread, but what specific sites are affected. So you might only have a small patch of psoriasis, but if it's on your face, it's going to be significantly affecting your day-to-day life. It might be affecting your confidence. If you've got it on the back of your hands, and that makes you very self-conscious. So we look at how extensive the disease is, but also what sites are affected. For instance, having psoriasis in your vulva, you might only have a small amount, but that's going to be really debilitating. It might affect your personal life. So those are the things we take into consideration. So the treatment of psoriasis depends on the extent, the site, what type it is, but there are general principles that we use. So the general principles as a starting point would be to think about a topical steroid. And topical steroids have been around for decades. They are safe. We know how they work, and we know the potential side effect profile. So a lot of people worry about topical steroid use, but when they're used under supervision, they are incredibly effective. So, it's really, we shouldn't worry about them. In dermatology, we like to use topical steroids in combination with other ingredients for psoriasis because it makes it more effective. So the steroids are a great anti-inflammatory, but we also like combining it with vitamin D, which is brilliant for psoriasis. We also like combining steroids with salicylic acid because that can help dissolve the scaliness of the psoriasis. And we also like combining it with coal tar, which is a great anti-inflammatory. So we don't tend to just use psoriasis steroids on their own. We tend to combine them, and that gives us better results and helps prolong remission. Now, if somebody's tried that and they've sort of reached a certain point, then we might consider something like narrowband UVB phototherapy. So that's generally only available in hospital. So as we've spoken about before, waiting lists can be very long. But if you can get there, the narrowband UVB is a great treatment for psoriasis. It's not a cure, but it can really be transformative for some people because it's generally low risk, very well tolerated, and it makes people feel really good. You know, you sort of stand in a very safe, measured light box with measured dosing, run by some very experienced, highly skilled nurses. So you get a really great relationship and you're seen by a clinician each time. So narrowband UVBs would be the next step. Now, after that, the treatment range has really exploded. And we could consider multiple different medications, which might be oral medications or injectable. And that's sort of getting into, you know, sort of treating more severe psoriasis or psoriasis that's really affecting your quality of life. So lots of different options. And I think that's the most important thing to say. There are lots of treatment options for psoriasis. So if your psoriasis is really affecting you, affecting your quality of life, affecting work or relationships, then please do not suffer in silence. There are things that we can do to absolutely treat and manage this really effectively.
And I think that's really assuring because, you know, I've met a number of people who've been so severely affected by psoriasis, and you just think you wouldn't wish it on anyone because not only is it what you're going through yourself, it's how people look at you. And we all know that is the really difficult bit. And people are very, I've been told, you know, people will say, oh, can I catch it from you? And that, you know, that's very hard, I'm sure.
Absolutely. I'm so sorry to hear that. But
Yeah.
and I think, again, that's where knowledge, talking about this really helps. Recognizing it absolutely helps. And also just really encouraging people to not to feel as if they're bothering anyone. You're really not bothering anyone. And I'm so privileged to work in such a wonderful unit, and we see such lovely patients, and so many of them start off by saying, I just didn't want to bother my doctor, or I didn't want to bother you. And I'm like, this is not a bother. This is absolutely something that you should not be suffering with. We can try different ways of managing things and work out what works best for you. So, you know, it's absolutely not a condition that needs to be suffered in silence.
But I think that's very key also with chronic conditions, because chronic conditions, there are, you know, most people know they are around for good, and it's how you manage them. And it is always long-term management. And so I think that's why people get into this thing of being bothering. So if it's acute, you see somebody and hopefully it gets sorted out straight away and there's no bother. But if you feel like you're going back year after year, and also having the stamina, I think, for want of a better word, is to keep trying, that there are, as you said, and there's more and more things coming onto the market. So keep trying and don't give up.
Yes, yeah, absolutely. And but that's hard, isn't it? That sort of level of resilience is hard. But I think you're absolutely right, you know, just sort of trying different things, because we're not quite there when it comes to personalized medicine. But, you know, what works for one person may not necessarily work for somebody else. So there might be an element of trial and error to begin with. And I think for some people that can cause them to lose a bit of confidence early on. But just to hold steadfast and keep on trying something else, because we will get to the point where something will work.
And I think the last question that we actually had on UVB treatments was, you know, we see them all advertised. There's a lot of home treatments for UVB lights. What, you know, I'm never sort of sure about it because, as I said, I'm always very concerned about using light. How do you feel? You know, what is the general medical view of home treatments?
So I have to say, on the whole, Katrina, I would say generally it would not be recommended to use a home UVB device. I think sort of that would be the official stance. And that's because ultimately, at the end of the day, UVB is UV radiation. And we know that radiation can be associated with skin aging, pigmentation, skin cancer. And UVB that is delivered in a clinical setting in hospital is measured very specifically, and specific doses are provided in each session. And the doses are changed depending on your response. So if you have a bit of redness, a bit of burning sensation, then we know to reduce the dose, and so it can be tweaked accordingly, according to your response. A home UVB device will not give you that precise measure of dosing. And potentially you may not recognize if you're developing a sunburn. And you may be tempted to sort of treat for a little bit longer than we would ordinarily treat in a clinical setting. So there's lots of nuances, lots of caveats. And I think it's probably sort of easiest to say it's not generally recommended. However, I do want to caveat that by saying, if you live in an area, for instance, where your closest hospital is tens, if not hundreds of miles away, or there's only one dermatologist providing care for your entire town or population, traveling to a clinical setting for UVB phototherapy 2 or 3 times a week, because that's what needs to be done, can be incredibly challenging. Or waiting to see that dermatologist can take a year, if not longer in some cases. So if you're able to see a dermatologist that has experience with home UVB devices and is able to give you guided doses, then potentially it could be an option. But I, on a personal level, don't recommend home UVB devices, but then I work in a very sort of, busy inner city location where we have phototherapy units. And I can not speak for those individuals that live in an area where they don't have access that easily to a clinical phototherapy setting. So on the whole, NICE is not recommending home UVB devices. There is no official NHS stance on home UVB devices, but potentially with the pressures that we're facing, we may get more guidance coming through.
And our last question. At the time when I obviously sent these questions to you, I just thought, well, I'm not sure about this one. But now, after listening to what you said about how psoriasis could, now this person doesn't say they have psoriasis, but I'm assuming that they possibly do have psoriasis. They've written, I'm a celiac. If I eat gluten, my skin flares up really bad. And yet then there seems to be no link between gluten and skin conditions. And I think you've answered that at the very beginning.
Yes, and also just a couple of other things to mention there with gluten specifically. So celiac disease is where you have gluten intolerance and you form antibodies. Now, there is a specific skin condition associated with celiac disease, and that's called dermatitis herpetiformis, where you get very itchy vesicles, particularly on the extensor aspects, so the outer parts of our skin. So I think with the person that sent in the question, we weren't clear whether they had psoriasis or not, but the fact that their skin flares up may be suggestive of a skin condition that's associated with celiac. So I'd recommend when the skin flares up, take photos, that's key, and then go and see, ideally, a specialist if they've got access to one in dermatology or GP, and then they can get some guidance as to what sort of skin problem there is. Gluten itself does have a subtle link with psoriasis, and that's because they are both autoimmune conditions. So we know that if you have celiac disease and you eat gluten, then you will cause inflammation in the gut, and that can manifest as inflammation in the skin. So there is certainly a link there.
That's really interesting. Well, you'll be pleased to know we've come to the end of I actually went for the most popular questions, and clearly the light was
Yes.
the real bit, and the sort of the treatments. So all I can say is thank you so much for a really informative chat.
You're very welcome. It's my pleasure. Thanks so much for inviting me to come and talk.
It was a pleasure. And thank you, everybody, for sending in your questions.
Yeah, thank you. Thanks so much.
Thanks. Bye.
Bye.